Virtual Monkeypox MPX Seminar, Science and Stigmas. The Zoom presentation covered monkeypox MPX, how it spreads, what the effects are, and what to do if exposed, followed by LGBTQIA+, Black and Brown community stigma and histories, hosted by the Epicenter of Monterey County, and sponsored by local organizations. Recording from August 23rd, 2022.
The Epicenter Monterey resides on the indigenous homelands of the Esselen, Rumsen, Mutsun, and Costanoan people. These are the original stewards of this land, and that is a relationship that cannot be severed by any colonial entities or systems. We must continually work toward a future in which their sacred role is truly honored, respected, and practiced freely. We must continue to put efforts into returning the land to its original stewards on the so-called Monterey County, that is the Esselen, Rumsen, Mutsun, and Costanoan. As our team engages with the community, we as the Epicenter seek to continuously educate ourselves on the indigenous history of so-called Salinas and Monterey County, as well as build up relationships with the living community members of these tribes to better serve our native youth community members. The people are the land. Remember that ancestors reside in this land. We are here, let Kalai. And we can take a moment for folks to continue putting their occupied tribal lands in the chat. And I want to note that your presence here is your consent to being recorded. We will be posting this onto the YouTube channel for the Epicenter later. And if you want to just come back and watch that there, that's fine, but your presence here implies your consent to be recorded. So now moving on to housekeeping items. I want to note that in an effort to make this seminar as inclusive as possible, centering LGBTQIA+, disabled, and Black, Brown, and Indigenous people, we have both ASL and Spanish interpretation services provided by the Office of Monterey County Supervisor, Wendy Askew. So if everyone go to the bottom of your screen and select your language, it's the little globe. You can select English or Spanish, or you can pin the ASL interpreter, whatever access you need. Those are the, excuse me, those are the tools present. And I'm hoping that the interpreters can introduce themselves in a little bit. I don't know if that's appropriate. Please let me know if that's not part. No, you're shaking your head. Okay, we can skip over that. Thank you to our interpreters for being here today. And to be inclusive of gender diversity and disability in the introductions, our facilitators and moderators and presenters will include their name, pronoun if they wish, and a visual description for blind and vision impaired people. So I'll go first, and then we'll move on to our moderators and then our presenters. So hi, my name is Ezra. I use they, them pronouns. I'm the drop-in services support staff here at the Epicenter, and your facilitator today. I'm wearing a pink and navy blue plaid shirt, glasses, and I am white with short hair and non-binary, but male presenting. And with that, I'll pass it on to our moderator, Angela.
Hello, can everybody hear me? Is this a good volume? Okay, cool. Hi, everybody. My name's Angela. I use they, them pronouns. I am the LGBTQ student service, LGBTQ student worker at the Epicenter. Sorry about that. I am wearing round glasses. I have a tropical shirt. I am non-binary, but female presenting person. And I'll pass it on to Victor or whoever is, yeah.
Victor might not be in here yet. He's in the other Zoom room, ushering people in. So why don't we pass it on to Haley?
Hi everyone, I'm Haley. I use they, them pronouns. I'm the media content creator of the Epicenter. Today I am wearing a denim hat, a black t-shirt, and I am non-binary and Latinx. And I will pass it to Rochelle.
Rochelle might need permission to unmute.
I did. Thank you. Hi, my name is Rochelle Santoya. I am the executive director of the Epicenter. I apologize, my internet is a little unstable, so my video is off, but I have red hair. I am female. My pronouns are she, her, hers, and today I'm wearing a black shirt. I am Caucasian, and I will pass it off to Jacob.
Good afternoon, everybody. My name is Jacob Agamau. I am the LGBTQ+ services coordinator here at the Epicenter. And I wanted to thank you all for taking part in this because it's very important to me that community come together to learn about crucial health information in our communities. I am non-binary, but male presenting with a beard. I have clear glasses, a shaved head. I'm wearing a gray V-neck with a rainbow heart-shaped pin on it. And I accept any pronoun, use with positive intent. And thank you for being here. And I will pass it to Eric.
Hi, everyone. My name is Eric Mora, and I am a policy analyst with the Office of Monterey County Supervisor Wendy Askew. I am gay and Latinx, and I wear glasses, and I have questionable facial hair at the moment. Thank you so much for being here, and I'll pass it on to Sam.
I don't think Sam is here. Oh, wait, they are here, but they're actually preoccupied. I'm gonna take it back, and we're gonna have our presenters introduce themselves if they're present, or they can wait for their presentations. So with that, let's start with Dr. Radner.
Okay, can you hear me? I think I was muted there. Okay. Yeah, hi, I'm Alan Radner. I'm an infectious disease physician here in the community. I have receding gray hair that's receding quickly every day with COVID and MPX now. And I have a white shirt, and I think I'll pass it on to Kristy.
Hi, I'm Mitchie. My pronouns are she, her, and hers. I am a white female with long hair. I take my glasses on and off, and I can't see very well with either way these days. And I'm wearing a blue jacket. I do work for the Monterey County Health Department. And then I'll turn it over to Evelyn.
All right, good afternoon, everyone. My name is Evelyn Alvarez. I'm the HIV Programs Coordinator for the Monterey County Health Department. Pronouns she, hers. I am a Latinx female. I'm wearing glasses and a tan sweater and my hair pulled back in a ponytail.
Thanks, and Stephen, could you go next? Quasar.
Hi, everyone. Yes, I'm Stephen Goings in Quasar. I use they, them, their pronouns. I am African heritage identified with a very bald head and some glasses. My head is usually tilted. I don't think you can see, but I'm wearing a blue work jacket that says Personal Growth and Counseling Center on it. I hope that's everything I was supposed to say.
Thank you, Stephen and Quasar. So what's next on the agenda is part 1 of the seminar, which will be presentations by Dr. Radner and Kristy Mitchie, followed by a Q&A. And then after that, we'll take a little break and then go to part 2, where we will have the community stigmas presentations by Stephen and Vanessa. Oh, I'm sorry, I skipped over Vanessa. I'm so sorry. Dr. Vanessa Lopez Littleton, could you introduce yourself, please?
Yes, it's fine, Ezra. So I'm Vanessa Lopez Littleton. I'm an associate professor and chair of the Department of Health, Human Services, and Public Policy at California State University, Monterey Bay. I'm a Black, heterosexual, cisgender female. Today, I'm wearing a yellow polo shirt. I have locks in my hair and some sassy tortoiseshell glasses. Thank you.
Thank you, Vanessa. So again, we'll move into part 1 of the presentations, which will be Dr. Radner and Kristy Mitchie talking about the monkeypox, how it spreads, and what to do if you contract it. And then we'll take a break. I'm sorry, then we'll do Q&A, and then we'll take a break, and then move on to community stigma, where we will get presentation from Stephen Goings and Dr. Vanessa Littleton-Lopez. So with that, I'm going to hand it over to Dr. Radner.
So I'm may need a little help here sharing the screen. Is it already up, or here we go? This might do it. Okay, can someone let me know if they can see the screen okay? Yes.
Looks great.
Okay.
Yes, we can see it. Thank you.
Okay. All right, thank you. So what I'm going to try to do is in about 15 minutes or so, maybe a little sooner if we can go quickly, I'm going to give kind of an interim scientific clinical update. I've been giving a number of presentations to the medical community. Kristy and I have been trying to get out the word on this, what we know about this scientifically. But I realize this is a little less scientific on an audience. However, it's still going to be a fairly scientific presentation because the reality is there's a very high likelihood that if you go see a provider right now with concerns, you may know more than they do. I mean, we're still trying to understand this, and we don't have a terribly educated medical community at the moment. So, again, we're not going to dummy this down. I'm going to, give this at a fairly sophisticated level and try to answer as many questions as I can when we're done. So I'm going to begin by, doing something a little inelegant, and that's using the COVID analogy, because I think we're all kind of steeped in COVID over the last few years. And unfortunately, this isn't a relay race. We're not handing COVID off. We're still dealing with COVID, but monkeypox or MPOX is a challenge that we're experiencing now. But I think it's appropriate to think back 2.5 years ago with COVID, and we thought about what did we know? Do we know how to diagnose it? Did we understand the natural history of the disease? Where were we getting testing? What were we telling people with respect to isolation? Did we have treatment? Did we have vaccination? All the same questions we're experiencing now. And the reality is we're still pretty early. I mean, we're probably closer to where we were at least a year ago with respect to COVID, using that as, again, as somewhat an elegant analogy. And I'll come back to that with the last slide. So let me say a few things about the science and about the disease and about treatment, and and then we'll turn it over to Kristy. So I'll just say a few kind of basic science things, that this is the MPOX or monkeypox or MPX, whatever we're going to call it, is a viral illness, and it's a DNA virus. And the reason I'm pointing that out is DNA viruses tend not to mutate as much as RNA viruses. And a lot of people have been concerned that this is going to change and we're going to see rapid variation like we've seen with COVID. And that's usually not the case with this group of viruses. This is in a family of viruses that are listed here called the Poxviridae. And variola is smallpox, which I'll say something about, which is only in humans, which is one of the reasons we've been able to eradicate it from the world. But there's close relatives. Vaccinia is a variant that isn't as aggressive, and it's a form that we use in vaccines. Cowpox is a relative. Monkeypox. It's important to point out that chickenpox is not a relative at all. So if you've had chickenpox, it doesn't protect you from getting monkeypox. But one of the critical things are that group of family or related viruses, getting immunity to one protects you from the other. We've known that. That's why cowpox vaccines or vaccinia vaccines protect you from smallpox. And we believe that the smallpox vaccines protect you from monkeypox. So having immunity to one provides cross-reactivity or protection from getting ill to one of the others. I'm not going to say a lot about smallpox. ID people like to talk about smallpox forever because it's one of the most horrific diseases known to man. It's probably arguably killed more people than any other disease known to man, in a extremely high mortality. And it's really this amazing disease that we eradicated using some of the strategies that we're trying to use with MPOX, that you can vaccinate people to protect them from getting ill. And if they've been exposed and you vaccinate them early on, as I'll talk about, you can mitigate or really lessen the disease severity they get and maybe even prevent them from getting disease. And that can prevent the spread. So what can I say about monkeypox, or as I think everyone knows, the name's changing a little bit. I'm not sure if it's MPX or it's MPOX or what name we're going to kind of fall on, but for the moment, we'll call it MPOX. And it's a bit of a misnomer, as everybody's probably heard. It really, the primary reservoir is in small forest animals, particularly rodents, small monkeys, but it was first identified in lab monkeys. And historically, there have been two what are called clades, or two strains. There was one in Central Africa and one in Western Africa. And maybe the most important part of that is that the Central African strain, which has been renamed the clade 1, as opposed to the West African strain, which is now called the shouldn't be a lowercase I, it's 2A, as opposed to what we're seeing right now at 2B. The 1A strain or the Central African strain seemed to have a much higher mortality. 10% of people in some series died. And fortunately, what we're seeing is a much less severe strain. We're seeing the West African or 2A strain. And right now, the mortality rate is profoundly lower than 10%, which is great news. It's been present for a number of years. One of the reasons we think it may be present is since we eradicated smallpox, people stopped getting the smallpox vaccine, so they weren't getting protection from monkeypox. So that may be one of the reasons we're seeing more MPOX. And there have been a few outbreaks that have been notable, even in the United States, as recent as 2003, having to do with imported prairie dogs, of all things. So that's what we've always kind of known about MPOX. It was something, you know, in sub-Saharan Africa, people weren't as worried about it here. But obviously, beginning in May 2022, we've had this outbreak, which wasn't related to people traveling to endemic areas. And I think, as everyone knows, it was initially involving men having sex with MSM, with the initial cases being predominantly in the United Kingdom, Spain, and Portugal. It's really exploded as, again, I think everyone knows, there's been 42,000 cases worldwide. Best estimate or number I can get are about 12 deaths. So that gives you a mortality rate that's very small, like 0.02%. Again, these numbers, one of the things I should have said at the beginning, one of the problems with giving talks like this, I learned this with the COVID pandemic. I would prepare slides at 8 o'clock in the morning, and by 5 o'clock in the evening, they were outdated. So these numbers are already probably outdated. But as of, I think it was yesterday afternoon, there was roughly 14,000 cases in the United States. It's important to point out that our first case was on May 18th, so it's been a while. California, there's 2,600 cases. And I think Kristy can update us, but I think she told me this morning there are 13 cases in Monterey County. So I'm going to talk about MPOX and talk about what it historically looked like and what we're seeing now, which seems to be different. So as I've mentioned, historically, this was happening in Central Africa, Western Africa. People had bites, scratches, ingesting animal products. They might have had a close family contact. Somebody might have coughed on them. They might have shared bedding. So these were people who were getting MPOX in the traditional way. One of the important things is it has a very long incubation period, which is why if you're exposed and you're vaccinated, we can actually prevent you from getting frequently any illness and generally speaking, seriously mitigate the illness. And that always confuses people. It's like rabies. You get bitten by a rabid animal and we give you the vaccine and you think that just getting exposed from getting bitten by a rabid animal would protect you, but it really doesn't generate the immune response you need. But fortunately, like rabies, with MPOX, that if you are exposed, particularly within 4 days, you get vaccinated, it will dramatically improve the course of disease. But during the incubation period, you're not infectious and most people don't know they have it. Then they develop what's called a prodrome, where they feel really achy and fevers and headaches, and they can get swollen lymph nodes. And then that's followed by this classic rash where you get, I've demonstrated the pictures here that go through this series of events. And it's very similar to what you do see with chickenpox. You get what are called macules, which are these flat red lesions, and they get bigger and they get pussy and then they open up and then you get a scab. Unlike chickenpox, with chickenpox, these will happen in waves where first you get it in your arms and then your chest and then your face. Historically, with monkeypox, this would all occur simultaneously or synchronously. The other thing that's very different is the lesions can be very painful, which chickenpox lesions usually don't hurt. And I think everyone knows they can scar, which is what smallpox can do. And chickenpox typically doesn't scar. And the natural history until this all resolves is usually a couple of weeks, 2 to 4 weeks. Rarely, as we've said, people can die from this. The little bit I can find so far, not a lot's been reported, but most of the deaths seem to be people that get brain complications or what's called encephalitis, but you can also get lung infections and eye infections and other problems. And the people who seem to get the most severe disease are people that are immunosuppressed, and that's a general category, but certainly advanced HIV or transplant patients. Pregnant women have problems with what's called some-mediated immunity, and they can get more serious disease. Children under 8 historically have got more severe disease. And we think people with skin disorders and bowel disorders, particularly if this is a sexually transmitted disease, may get more severe disease as well. So what's different about what we're seeing in 2022 so far? It's like, again, analogous to COVID. we're learning as we go. It seems to be a bit different. People are getting fewer lesions. They seem to be happening at the site of physical contact, which can be anal, genital, mouth. We're seeing cases of proctitis. We're seeing these asynchronous lesions where they may be starting in the genitals and then spreading to the chest and the face. They don't seem to necessarily have that same prodrome. It's just the first thing they experience is the rash. Fortunately, the mortality is low. And I've got a slide here that kind of goes through, and I'm happy to share the slides that describe some of the atypical features that we're seeing. So, what are the patients that we're worried about? Again, I harken back to COVID, to COVID, where we were talking about people getting off cruise ships and people, with severe travel to endemic areas. So there was this discussion about who is getting MPOX, and originally it was people with, social networks, MSMs, it's listed here, travel, classic rashes. These are the people that had high index of suspicions. We all knew this wasn't going to, stay in one specific community. And every day there's reports about this expanding. There's women, there seems to be contact with what we call fomites or transmission with clothing, glasses, etc. There have been childcare workers. I was on a call with some healthcare systems in New Jersey where they've seen it in children now. And there's actually been a report now of it happening in a dog in Paris. We also know, unfortunately, unlike smallpox, this can occur in pets. So let's get to some of the other questions. So testing. Testing has been a challenge, I'll say, for a lot of reasons. And again, I'm not gonna, when I talk to medical staff, we're talking about how to institute testing protocols and where to do it. But first of all, if people remember early on, there aren't a lot of labs to know how to do the testing. There weren't reagents, there weren't facilities. Just like with COVID, you potentially could get infected doing an acquisition. I'm going to talk about how it's spread, but theoretically you can have oral lesions, people could cough on you. So you really have to do all of these, what we call, PPE or personal protective devices to prevent you from getting infections that everybody's heard about with N95 masks, gloves, eye protection gowns, negative pressure rooms. It's a real challenge. And what, is even more challenging than with COVID is that the lesions are, in locations that may be harder to test. I can't do a drive-through testing spot like I could do with COVID out in front of, an emergency department when these are, genital lesions. So it makes it harder. There's also people that don't necessarily want to come in because of stigma, and because, as we'll talk about, I think all of us collectively are going to have to work to remove stigma, and also concerns about isolation. If you're positive, you have to go into isolation, as we'll talk about, and no one really wants to do that. So there's a lot of challenges, both operationally to do testing and as a community to get widespread testing. Again, I'm not going to go into all of it, but this is a PCR methodology. Just as we had with COVID. And one of the other concerns is that a lot of these patients, unfortunately, also have other sexually transmitted diseases, particularly if this was acquired sexually. So there's reports about people having syphilis, gonorrhea, chlamydia, other concurrent sexually transmitted diseases. So they need to be generally tested for sometimes many things at once. If you are suspecting a case, and I'll let Kristy talk more about it, the health department really needs to know, because of, as we've talked about, both they'll kind of direct the isolation requirements, and as we've talked about, to really try to get this under control, to vaccinate contacts is critically important. So the numbers are here to contact them, and you can reach them after hours. We're trying to, Kristy's working on this, we're all working on trying to where we can test, because we've already talked about it, it's difficult. I'm the chief medical officer and the CEO of the Salinas Valley Medical Clinic, and in the CMO for the hospital system. And we've worked with Doctors on Duty, our partner, where they're doing testing on South Main and Lighthouse. I know that the Montage system has it on Mogo. Emergency departments are testing, although, it's a difficult place to send people. We'd rather do it in urgent care centers rather than have to wait in lines and, swamped emergency departments. And Kristy may have some updates in other locations. These are the ones I know that are doing testing. I know Planned Parenthood was trying to discuss it, but again, I'll leave that up to Kristy. I don't know of other locations at the moment. So what do we tell people? As I've already said, we've already talked about how it spreads, skin to skin, Fomites means something like glasses or some inanimate object that somebody's talking to, drinking glasses or clothing or, swabs, etc. Our belief is that from the time symptoms start, you're infectious until the scabs fall off. During that incubation period, you're not infectious. And as we've already said, the Monterey County Health Department will help you with isolation. And there's some recommendations. And actually, I've got in the next few slides is we have kind of realized that this doesn't have a 10% mortality. And, it may not be as horrifically, lethal, so to speak, that there's evolving recommendations about what you can do. And this came out just a few days ago from CDPH. I've got 2 slides on it. I'm not going to go through all of them, but it was, we were telling people you had to stay in your house and have virtually no contact and all these recommendations until your scabs fell off, which could take 2 to 4 weeks. And we learned with COVID, people need to go out and get food and they need to make a living and they need to feed their family. And we've never done a great job providing care for people when they couldn't leave their house and we were putting them in isolation. So there's evolving recommendations, and now you can go out with limited activity if you don't have fevers, respiratory symptoms, no new lesions for 48 hours, and the lesions can be covered. If you have them on your face and they're coming out, they're still recommending you stay in isolation, but there's more expanded recommendations about people leaving. And there's also return to work. Again, I'm not going to read through these. We don't have time for it, but you can look at it. But assuming you're not in a high risk occupation like a healthcare worker or you're working in daycare, people are being allowed to go to work and resuming normal activities. And that's when you're kind of back to normal. And the recommendations are, as I've said, when the lesions of all the crusts have fallen off and you don't have any active lesions. And the one exception to that is there's been some recent literature that men will continue to pass potentially viable MPX virus in their sperm for up to 12 weeks after seeming to have resolved illness. So the recommendations is that they use condoms for at least 12 weeks with sexual activity after having MPX. A few things about treatment. So again, I want to be honest about it. First of all, the vaccination is treatment. As we said, if you get vaccinated within 4 days, it's probably going to make it so that you will either not have disease or have minimal disease, and probably up to 14 days, it functions as treatment. There are some antivirals. The main one everybody's heard about is TPOXX or tecovirimat. And I'm not going to go into the whole complicated elements of it, but basically this was a drug that was approved for smallpox in 2017 after the anthrax bioterrorism attack in 2001. And actually it's got this weird history that it was approved by the FDA, but it could only be in the strategic national stockpile. And only the CDC could determine who would get it. And right now the CDC is making it generally available, but they prefer it all to be since we really don't have a lot of experience using it in humans, this is really based on animal data and some pharmacokinetic data in humans and a few anecdotal reports that they're recommending that everybody be in an experimental protocol. Initially, this was a nightmare. It was like a 128-page document and it was impossible to enroll people. And it just became, incredibly unwieldy. So the CDC has actually made it a lot easier. And again, Kristy can talk about it. I'll just say we don't have a lot of it in the community. As of this morning, we had 5 courses of therapy. So we're really trying to save it for people who we think will have a really bad disease. And we've kind of talked about who's at risk if you get severe disease, if you're immunocompromised. Again, if this was generally available, we'd probably give it to just about everybody, but we're trying to be a little more careful about using the drug when there's very little. There's a few other drugs, which I won't go into. There's a drug called cidofovir, which I've used for a long time for HIV patients. But those are drugs that are available for severe disease for people that are hospitalized. Most of the therapy this was from a WHO clinical guide, which basically says you're treating people, symptomatically. So you're trying to hydrate people. I've heard anecdotally that calamine lotion really makes people feel better, giving anti-inflammatory medications. But this is a huge chart basically saying you're treating people as symptomatically as best as you can. Vaccines. So again, no specific vaccine was approved for monkeypox. The vaccines that we're using are for smallpox. There's 2 vaccines that are available. There's something, the older one called ACAM 2000, and many of you remember, this is our smallpox vaccine, and they use this weird thing called a scarification technique where they scrape you and puncture your skin, and you would get, immunity for smallpox. We think it works for monkeypox. The problem with this is it's what's called a live attenuated replication competent virus. So even though the virus is very, very weak, it can replicate, and in severely immunosuppressed people, there's reports about them getting very ill, where it just, actually people have died, something called progressive vaccinia, or very severe skin infections, or what's called myocarditis. So we're trying not to use that in place of the newer vaccine, which I'll talk about in a minute. A lot of people have asked, if I was vaccinated for smallpox, do I still have immunity? And no one really knows. The general understanding is that after 2 years, your antibody levels fall pretty rapidly. And after 10 years, you really don't have measurable antibodies. As we're learning with COVID, having measurable antibodies may not be the end all, so to speak. If you have what's called memory B or memory T cells, even if you don't have a lot of antibodies in your blood, you still may have a good response. So we're hopeful that people that were vaccinated more than 10 years ago may have some immunity, but if you have an exposure, you have the opportunity to be vaccinated and you haven't had a smallpox vaccine in 10 years, everyone's recommending you go forward with it. The newer vaccine is what's being referred to as the Jynneos vaccine. And it's also what's called a live attenuated. It's not a dead virus, but it's weakened and it's been altered so that it can't replicate. So no matter how bad your immune system is, the virus is unable to perpetuate or replicate, which makes it a lot safer. We were giving subcutaneous doses a month apart. I think a lot of people may have heard that actually due to some immunology issues that you have in your skin, what are called many more antigen presenting cells, you can give a much smaller dose by this intradermal method and get an equivalent response. And the good thing is you use a lot, you use about 1/5 of the dose. So we used to use an entire vial. We can often get 3 to 5 doses out now. So we're trying to spread the amount of vaccine that's out there. Again, getting this, and Kristy will talk about it. We have daily discussions about this. If we had it for everybody, we, just be opening it up. But it's now you can go into any, CVS or Walmart and get a COVID vaccine. We're really trying to, get this out as best as we can. What happens is the feds send the limited amount they have to the states sends it out to Monterey County Health Department, and then the Monterey County Health Department decides where we're going to do it. And I think to date, we've been saving it for those exposures where we know we can mitigate disease and try to stop the spread. And we're trying to high-risk individuals, which at least initially have been the 2 HIV clinics in Monterey County. But Kristy can talk about, as we get more vaccine, how we're trying to roll this out. I'm not going to go into this slide. It's just the risk groups that the CDC and the state CDPH are using for guidance as to the priority groups. And I think everybody's heard these before. And this is the last slide. So again, going back to COVID, I mean, I wish I could say a lot more things at this point. I think we're all dealing with uncertainty. We're learning about mortality. We're seeing atypical spread. We're seeing atypical manifestations. There's a lot of misinformation out there. There's, inappropriate comments and finger pointing and name changing and all the things that I think other speakers are going to talk about. So we're trying to work our way through that. I've already talked about the technical challenges with testing. There's also the social challenges. I mean, there are very limited sites right now in the county, so we're working through that. Unfortunately, the isolation may be very prolonged right now. We've already talked about social and economic consequences of being in isolation. And then, the county and this state have shown no interest in anything with respect to enforcement. And again, I'm not, suggesting how, militaristic we should get, but we knew people with COVID that were going to parties with active COVID before we had vaccines, and we thought this was a fatal illness. And the police, not only the sheriffs have no interest in, enforcing this, but they refuse to get vaccinated, frankly. Treatment, there's, as we already talked about, very limited availability, coordination, and the process and actually getting drugs is problematic. And as we've already talked about, we're having the same challenges with vaccination. The good thing is compared to COVID is there is we do have testing much more rapidly. We don't have to create testing de novo like we did with COVID. We have treatment. We just got to get it out and show that it works. And we have a vaccine, and we have vaccines. We have to manufacture them, not go through very basic studies to even see if they work. So, I think we're all pretty optimistic that we can deal with this, but it's also pretty frustrating. I mean, we're in mid-August now. First cases were in May. And, I don't think we did a great job as a nation and as a world in trying to control this early on. I mean, this is something that we had the ability to really get out there and limit. And, it's the number of cases continues to increase dramatically. And we're, doing our best at this point, but it's hard to feel, terribly sanguine about the work we've done in public health over, since COVID and what we're doing now. But again, I'm going to stop. There's some references here. I really appreciate everybody that's, taking the time to listen to this and helping us message and, helping work with us. And, again, I think Kristy and the health department have a lot of challenges that I'll pass over to her and let her kind of talk about what they're trying to do to, resolve some of these complicated issues that we're dealing with. So I'll stop. Kristy, got it?
Okay, thanks, Dr. Radner. Lots of great information. I'll just focus on a couple of pieces so that try to provide a little bit more clarity around where we stand here in Monterey County. I think the first, things people want to know is, if I'm exposed, what do I do? If I have symptoms, what do I do? And for all the reasons Dr. Radner explained, sometimes that's not an easy question to answer. I'll start out with, and I will say both of these, all this information is on our website, which is mtyhd.org/monkeypox. But you can, if you're exposed to somebody who, you get a call, I was at a party, there was somebody with monkeypox there, please do call our communicable disease unit. We are providing vaccination. As Dr. Radner mentioned, if you get vaccinated, within an appropriate time period, it can either prevent disease or make sure that you have really mild symptoms. And it's important to do that in a timely fashion. It's not an emergency, but it's something that you want to take care of in a few days. So please, if you are exposed or hear somebody that's exposed, point them to the health department. We're happy to vaccinate, and our nurses are available to do that. We're trying to accommodate people's schedules as best we can to get folks in. The second, question is, well, what do I do if I have symptoms? And that does become a little bit more complicated because the symptoms of monkeypox can be very similar to many other diseases. Because of that, the best thing to do is contact your medical provider. Not that I'm saying your medical provider may be able to see you and evaluate you. They may refer you on to another location where you can be evaluated. That may include testing. And then while your test is pending, they will instruct you to stay home until your test results come in. Depending on the degree of disease or clinical presentation, you may get a call right away from a public health nurse that can kind of help you walk through that. It may be a day or two before a public health nurse can reach out to you, but that's sort of the general process. In terms of, besides the places that Dr. Radner mentioned that are testing, our county FQHC clinic system is testing. So places like Seaside Family Health Center, Alisal Health Center. There are some private medical offices that are testing, swabbing in their office and sending off. Again, it changes kind of from day to day. So the best thing to do is, kind of call first to see what services are available there locally. Kind of shifting into more of the treatment realm, treatment is still really hard to come by. Unfortunately, I wish it was, like a general antibiotic that you could get really readily, but it's not. The process is that it kind of flows from the federal governments to the states. The states only get so many doses per week, and then they're distributed out to medical providers who have gone through this kind of arduous process with the CDC to get approved to receive TPOXX, calling it for short. And I will say that Monterey County Clinic Services, like places like the infectious disease clinic that's associated with clinic services called NIDO, is going through the process to be an approved treatment site. So we're hoping within the next, within the next week or so, that will be a location that if you're diagnosed, your medical provider can refer you there for treatment and have that available for you. As Dr. Radner mentioned, we have very few doses here in Monterey County. Right now, we still have 5, we can treat 5 people right now. So we really are trying to make sure that we're prioritizing the sickest of the sick among us, and that's not a great place to be in. We're hoping that there'll be more providers who might be able to complete the CDC process and have a way to bring patients in and adequately treat them. And as we get more information on that, we'll be sure to update this group and keep information as best we can posted on our website.
I apologize for interrupting. Our interpreter is asking for us to slow down our speaking.
Thank you. Sorry. I will try to do that. I do talk fast. So my apologies. Feel free to, wave your hand if I continue to do that. Regarding a vaccine, I think the supply of vaccine is really much lower than what we need to serve our needs, both here locally and across the state and the nation. To date, Monterey County's only received 418 doses of the Jynneos vaccine. Of these, we've distributed about half of those to the HIV care clinics in Monterey County, trying to cover the most at-risk of the at-risk populations, people with immunocompromised conditions. We also vaccinated about 75 people who self-identified as a contact to somebody who had monkeypox. So they were in close contact with somebody while they were infectious. We have changed here at the health department, are using the intradermal route of vaccinating. We switched over to that very recently. And I want to just be clear that this method has the same efficacy as the subcutaneous method that we were using before. It just uses less vaccine, and it's not a smaller amount of vaccine, it's the appropriate amount of vaccine for an intradermal injection. So that's the way intradermal injections were designed to function, is with a smaller dose, which works out perfectly because we can spread our doses out a little bit more. So we did our first clinic where we were using this intradermal method at Pajaro Pride this last weekend. And we have another clinic scheduled for this coming weekend. And in just a minute, Evelyn's going to give us a little bit more information about that, about how people can access it, where to go, those sorts of things. But from this point forward, since we can stretch our vaccine a little bit more, we are in public health hoping to host clinics like we have for COVID. So there would be a way to schedule an appointment or to walk in. You can come in and get a monkeypox or MPX vaccine and Jynneos vaccine. We are utilizing the CDPH's, California Department of Public Health's priority groups. Those are available publicly on the CDPH website because vaccine supplies still are limited. We can't vaccinate everybody we want to, so we have to prioritize a bit for now. There's one other thing about vaccine that I wanted to say, but I've forgotten it for the moment. I'm hoping that the supplies will continue to increase and that vaccine will be available in a broader context at more provider offices, at pharmacies, but we're just not quite there yet. And I think with that, I'll turn it over to Evelyn Alvarez, who is our HIV programs coordinator, and she can talk a little bit more about the clinic coming up this weekend and other resources.
Thank you, Kristy. I will go ahead and share my screen. That way you all can see the flyer that we have up. All right, so yes, like Kristy mentioned, exciting news. We will be hosting a MPX vaccine clinic this Saturday, August 27th from 10 a.m. to 4 p.m. And it's going to be at the Breadbox Recreation Center in Salinas. On the left side of this flyer, sorry, you probably can't see my full screen. However, I have shared these flyers with the seminar organizers, so definitely we will share these out to people who are attending today. On the left side of the screen here, you will find the eligibility criteria outlining our priority communities eligible for this vaccine, for the Jynneos vaccine. We will be hosting our first, we'll be offering our first doses. And this vaccine will be offered at no cost to residents, regardless of insurance or immigration status. All right, and one of the questions that I had earlier, we highly encourage folks to register prior to the clinic to help reduce wait times for folks who are not able to register online or have any questions. We will be accepting walk-ins, however, this will depend on vaccine availability for the day. So it'll be for first come, first served basis for people without an appointment. And lastly, staff will be on site to help answer any questions or help with registration. And most importantly, how can people register for this vaccine clinic? Please feel free to utilize this QR code that is right here at the bottom of the flyer. And also folks can utilize the bit URL to be able to register prior to the clinic. For folks who need registration in Spanish, we created a Spanish flyer as well. And the QR code for the Spanish registration is on the Spanish flyer. Please feel free to share this flyer to people in your communities who you think you might benefit from the opportunity. We're very excited to be able to offer this to community members who are eligible. And then now I will go ahead and share additional resources here. And on the screen, you'll find additional informational resources. For local MPX information, please check out our Monterey County Health Department website. Like Kristy mentioned earlier, we also have our Monterey County Health Department Communicable Disease Unit. You can contact us at 831-755-4521. And feel free to check us out for our social media, Twitter and Meta, which is formerly known as Facebook, and Instagram. Here, people are able to see what our teams are doing out in the community and any recent updates that we would like to share with everyone. In addition, we've included some CDPH and CDC MPX websites for future reference. This concludes our presentation for today. Thank you so much for the opportunity to share and the space that we had today, and I will turn it over to Ezra.
Thank you all so much. We're going to take about 10 minutes for Q&A, and then after that, we will have a little break before we move on to part 2. So I'm going to share my screen with the Q&A flyer. I hope it's if it's super distracting, we don't have to have this on. See, now I can't see it, everyone. Can you all see this?
Yes.
Okay, great. So the Q&A, we'll just open the floor, but I wanted to start with one of the questions in the chat from Carla. I believe this one is directed at Dr. Radner. Not sure if this has been asked, but have vaccine dosages changed from the original vaccine dosage?
Yeah, I think Kristy kind of spoke to this. We're using a fifth of the dose, but it's not truly a fifth of the dose. There's different ways to administer a vaccine, and we know from lots of vaccines that if we give what's called intradermal, or you give it basically within the skin layers, your immune system responds significantly better than to give a subcutaneous shot or the way we do most vaccines. So we know historically that you can use a smaller amount and get the same response. The reason we haven't done it, just to be honest, is it's a little trickier and not everyone knows how to administer it. I don't know if anyone's ever had a tuberculosis skin test where it goes just under the skin where they make that little bubble. That's how they have to administer it. But if they do it that way, it's the equivalent to getting the traditional dose. So it's a fifth of the dose, but it works just fine if administered in a slightly different way. Okay.
Thank you, Dr. Radner. And we have a question from Chris. I'm not currently in the high-risk group identified in Evelyn's slide, but since I'm LGBTQ, I'd like to be vaccinated when vaccines become more broadly available. Do you have any idea when that would be, Evelyn?
I will go ahead and turn that over to Kristy.
Well, I think the honest truth is we don't know. We don't know how many vaccines we're going to have here at the health department from week to week. So there's just no long-term projections. We're hopeful, the federal government is stating that they will make more vaccines available. Certainly there's lots of folks advocating at the state level to the federal government to try to get more vaccine available. So I appreciate that you want to get vaccinated. We want to vaccinate you. I don't have a timeline for you.
Thank you. If anyone else has questions, you can raise your hand and we can unmute you, or you can put it in the chat and I will read it out loud. Gosh. I'm going to stop my screen share because it's like it's very difficult for me to do things with this on. Okay, if there's no more questions, we can break until 5.
I'll just jump it right in. Sorry, Ezra, I have my camera off. Maybe you weren't able to see me.
Thank you.
Question for Kristy and Evelyn. What can people expect when they do show up to one of the vaccine clinics? Like, what's the procedure like?
Of course, I can go ahead and answer that. So usually, typically when people show up to our vaccine clinics, similar to our COVID clinics response, we are able to, if we have accessibility for check-in and walk-in appointments, people are able to walk in. They are greeted by staff members. They are asked about eligibility, also just typical screening questions. And if folks need assistance with registering for an appointment that same day, if we have the vaccine available, people are able to receive assistance in registering. And then after that, they'll go ahead and move forward with the clinic flow. They'll be able to speak to a clinical staff if they have any clinical questions, and from there they're able to get vaccinated. After they receive the vaccine, we typically, clinical staff will decide if they are going to be eligible for a 15 or a 30-minute observation. And depending on how long they are there, they're observed by a clinical staff, and also there's more support staff to answer any questions. So we definitely encourage for folks for this specific clinic to just register prior to the clinic online, and this will help with the waiting line and the waiting time when people show up.
Thank you, Evelyn. Our next question is from Carla. It's a two-part question. Do you recommend children being vaccinated, and at what age? What's the youngest age that can be vaccinated?
I don't know if Kristy wants to take it. My understanding is the general approval for the JYNNEOS vaccine is greater than 18. The older vaccine was greater than 1. But I know we can get waivers, and we've actually given, I believe we've given it to under 18 that had exposures in that so-called ring vaccination or post-exposure vaccination group. But generally speaking, again, this may evolve, but at the moment, my understanding is a recommendation for the JYNNEOS vaccine is greater than 18. Is that your understanding, Kristy?
Yes, there is an EUA now for children under the age of 18. And so if there's been a significant exposure, a household exposure, then we would vaccinate. The younger the child is, if we're talking about a very young child, we'd probably be doing a little bit of consultation with a subject matter expert before we would vaccinate to make sure that we had, everything was appropriate. But yes, children can be vaccinated.
So I have a question and follow up to that. What will the county's response be if this virus spreads through the schools? Because children are not exactly germ conscious.
Well, there is the CDC and CDPH are putting out guidelines for how to help schools prepare for that situation. Just like with COVID, there was guidelines out for schools. CDC has some guidelines out right now for schools and childcare. I'm not sure if CDPH has their own guidance, but I'm sure it'll follow soon. So the first step is preparation for that. Second step is, if we would treat school outbreaks very similar to what we would do for an outbreak of another kind of communicable disease. I can't say that we will have enough vaccine to vaccinate schools, if this gets into schools and spreads very quickly in the short term where we don't have vaccine, we wouldn't be able to vaccinate. We'd have to rely on some of the other non-pharmaceutical methods of controlling disease, which include, isolating kids, keeping kids home from school, potentially keeping the classroom closed and going to tele education for, through the incubation period. Those types of measures is what we'd have to lean back on.
Thank you. We have a question from Chris. Does wearing long sleeves and pants reduce MPX risk in crowded clubs and bars and other high-risk areas?
So I'll start, and maybe Dr. Radner can jump in and either offer an alternate opinion or expand on this. I would say it will reduce your risk of skin-to-skin contact. However, what we do know is that monkeypox can be picked up on clothing and survive on clothing. So what I would say is if you're going to, a rave or a party where you're going to have be a lot of close contact with long sleeves on, as you take off your clothes after you come home, be very careful about how you do that so that you try to minimize contact with the outside of your clothes to your skin, and make sure you wash those clothes in hot water and a hot dryer.
Thank you, Kristy. Did Evelyn or Dr. Radner want to add to that?
I think that's right on.
We have time for another 1 or 2 questions, and if not, we can go on to break. So I'll wait a moment and let folks get a chance to ask. Remember, you can raise your hand or put it in the chat.
I think someone has their hand up.
Do they? Oh, I don't.
Hi, yes. I have plans for an upcoming dance party that I might attend in the LGBT community, and wanted to know, besides wearing long sleeves and being careful how I just robe when I get home, what other things I can do to help protect myself?
Evelyn, do you want to take that, or do you want me to?
You can go ahead.
So I think, trying to minimize skin-to-skin contact is probably, a good strategy for now. Trying, if you have the ability to, if the party is indoors and outdoors, spend more time outdoors than indoors. Another, if you're going to have a really close contact with someone, it's okay to ask somebody what their health status is, if they, if they've been sick recently, and kind of make sure that you're having that communication before you have really close contact with someone.
Thank you. Let's go on to break. We'll take a 10-minute break and reconvene at 5:45. I'll put up a little sign here and some smooth jazz music, and I'll see y'all when we come back, yeah? Welcome back, everybody. I hope everyone was able to make it back. Our part 2 of our seminar is the stigmas of monkeypox as it pertains to the LGBTQIA or queer community and the Black community. So we're going to start with Stephen and Quasar Goings, who will be giving a presentation on HIV/AIDS stigma in the queer community, followed by Dr. Vanessa Littleton-Lopez giving a presentation on monkeypox and the Black community. So with that, I'm going to hand it over to Stephen and Quasar Goings.
Okay. Well, hello, everyone. Let me see. I'm turning on my slideshow. Give me a thumbs up if you can see the slide. Yeah. Okay. Great. So I feel like a college student cramming for a test. because I've been so busy, I told Ezra, even while we were talking, even while we were listening, I was putting together the PowerPoint. So that's where I'm at in terms of how busy I am. But I thank you for letting me be here. My understanding is that I've been asked to speak about the parallels between monkeypox and HIV/AIDS, in particular, how both diseases were initially or eventually initially found in highest concentration within communities of men who have sex with men, or as I'll put it, because we often think of gender and biological sex as the same thing. I have my own kind of personal convention in which I refer to sexual biology as male and female, and I refer to constructed binary constructions of gender as men and women. So let's see. So here's basically my idea. I'm gonna this will be maybe 20 minutes. I'm editing even as we speak, but I'm going to talk about some facts. I'm going to give you my personal story in relation to HIV/AIDS. I'm going to talk a little bit about my own take on the kind of spiritual and social justice lens that affects not only HIV/AIDS and monkeypox, but many diseases. And then the last thing I'd like to do is share a resource that I found that's a very sex positive messaging, specifically for gay males. So just to reiterate, a much shorter version of some facts, and I should say that everything that I know about monkeypox, I have learned in the last 2 days. So all I knew, I heard this disease out and about, and I got vaccinated, and I didn't think about it again until Ezra called. So HIV/AIDS is a virus that attacks the immune system. Monkeypox is a viral infection similar to smallpox. HIV/AIDS has some African origins. It became a global pandemic starting in the 1980s. Monkeypox also has some African origins. There are 11 African countries in which it is endemic, but the global outbreak, such that it is, just started, I think, in like May of 2022. For HIV/AIDS, it ends up being a slow collapse of the immune system. For monkeypox, it is generally flu symptoms and a rash within just a few days. With HIV/AIDS, it's usually eventually fatal if untreated. With monkeypox, typically it's mild, although it can be fatal. Primary means of transmission with HIV/AIDS is anal and vaginal sex and needles. And with monkeypox, it's direct skin-to-skin contact, as has been said before, contaminated objects. And I read, and I'm sure the health folks will correct me if I'm wrong, but what I read was it may be in breath droplets as well. I also want to say what monkeypox is not. It is not something that comes from monkeys, as was already debunked. It is not AIDS. It is more infectious than AIDS, but less dangerous so far. It is not VAIDS. I don't know if you've heard this, but there in some social media, some social circles, all these kind of conspiracy circles, there's this idea, remember how politicized COVID became. So there became this idea that that monkeypox is essentially acquired through the COVID vaccine. And so they came up with this word VAIDS, but that is thoroughly not true. That is not true. It is not generally fatal. About maybe between 3 to 6% of people who contract it may die of it, but it is often painful, I understand. At the moment, it's not very prevalent, less than 50,000 people worldwide compared to HIV/AIDS, which is greater than 38 million. I should say yet, because every week I'm understanding that cases are doubling. And the last thing is that I'll say is that it's on this level is that it's not a gay man's disease. So I'm going to tell you a little bit about my own personal story, my HIV/AIDS story. Shortly after graduating from high school in 1981, I saw a segment on the news in actually my seaside home that I'm still living in or reliving in which I saw a news story about some mysterious disease that was killing gay men. And the original acronym that eventually became HIV for human immunodeficiency virus, HIV, the virus that causes AIDS. The original acronym was GRID, gay-related immune deficiency. Again, because in the U.S. this is the population that they first saw in great numbers, and that's important because homosexuality already had a stigma upon it, and therefore, really, what happened was by initially calling it GRID, gay-related immunodeficiency disorder, it immediately and perhaps permanently affixed a stigma to the disease itself, the stigma that was already present in the HIV, in the gay community. So much so that the word gay itself was quickly turned into a punchline acronym that some older folks might remember. People would joke that gay stood for "Got AIDS Yet?" So that's how strong that that connection was. Despite real fears about San Francisco being one of the epicenters of the disease, for me growing up here in the mostly Black, at least at that time, city of Seaside, or the largest Black population for sure. Well, it was a place that was, it's a city that has very strong military and church cultures, both of which are historically anti-queer. So that kind of discomfort in being here as a gay person was more powerful to me than the fear of the disease. So I moved up to San Francisco in 1986 during the height of the AIDS crisis. In fact, I remember when I moved up there, I remember at Walgreens in the Castro, there would be a line 2 blocks long outside of Walgreens for people picking up their AZT AIDS medications. Every week, I would look through the gay newspaper, the Bay Area Reporter, to see if I knew anyone who had died that week. In 1990, I too was diagnosed with HIV at the age of 27. And life expectancy at that time was about 18 months from diagnosis to death. It was understood to be a 100% fatal disease at the time. So 3 years, you got to live 3 years if you were really lucky. In 1996, so that's 6 years later, so I'm still alive and kicking, I lost my first partner, whom I had been with for 5 years, Jim, to AIDS. In 1999, I lost my second partner, Adam. By 2002, I had lost scores of friends. I fell into a cycle of depression and substance abuse that landed me in the hospital with full-blown AIDS and caused me to move back to Seaside and to get on disability. It took me a really long time to finally recognize that that I was going to survive the disease. So at 40, I don't know if I put this in here. No, at 40, I started my freshman year at college at MPC, and I went to the AIDS clinic at Community Hospital, often called OPUS, Outpatient Immunology Services. They finally succeeded in getting me on medications and hooked me up with the Monterey County AIDS Project, which got me into rehab and subsidized housing in Marina. In 2006, that housing program was discontinued, and I was faced for the first time with the real possibility of homelessness. But I was very fortunate that there was actually the service learning student is on the call today with us. A couple of service learning students at that time at MCAP told me that as a graduate of NPC, I would automatically be accepted at CSUMB, and that I could get into East Campus housing. So that's basically how I got here. And I discovered my inner activist while I was at CSUMB. I'm not sure what, okay. I really began to live out what I call my purpose in life. I have two primary purposes in life. The first is to empower people to discover and live out their own unique calling to contribute to humanity and experience fulfillment. And that's what I've been doing over the last 10 years or so. And an even longer purpose in life for me has been to break down the barriers between belief systems and support people in finding their own paths to healing, spirit, and wholeness. And the way that relates to this conversation is, it's a belief system. Homophobia is a belief system. Racism is a belief system, right? And these belief systems that some people are better than other people or worse than other people create stigmas, and different people are treated differently. So I would say personally, because I am a spiritual person, that it is only through God's grace that I have lived long enough to discover that our greatest potential is realized through service to others. And while it was the love and support that I have received from others that saved my life, it is through the contributions that I've made since then that I have found real value and joy in living. And so this will be as close to, a proclamation that I'll make. But for everyone that is here who is under 30, I want you to know that both lives that I have led, from the darkness of AIDS and drug addiction to the bright light and of service and contribution, are equally available to you. The first word in AIDS is acquired. And despite all the medical advances of the last 30 years, the hard truth is that your generation is absolutely at as great of risk as mine was in contracting AIDS, maybe more so, if you think that it is the disease of a previous generation and fail to take it seriously. From where I'm sitting, the only thing that has changed, in the West anyway, is that fewer people are dying from the disease as before. But trust me, living with HIV is no picnic. My medications cost over $1,500 a month. And there is still a terrible stigma attached to the disease. And when it comes to dating, disclosure is both necessary and terrifying. So I'll end this part one with one of my favorite Bible quotes. Today I have given you the choice between life and death, between blessings and curses. Now I call on heaven and earth to witness the choice you make. Oh, that you would choose life so that you and your descendants might live. So I'll go on now to, having introduced a Bible verse, to focusing more directly on my experience as a gay man living with AIDS in the Black and mostly Christian community, which is one of many different circles that I run in. For the first few years, when this disease was only or mostly associated with males who have sex with males, most national religious organizations were officially, and I would argue shamefully, silent on the subject. But supported by religious doctrines that condemn homosexuality, clerics preached in pulpits all across the world that AIDS was divine punishment for the sin of homosexuality. African Americans are widely understood to be the most religiously oriented ethnic group in the United States. And not only that, most Black Christians belong to religiously conservative churches that interpret the Bible literally. Regardless of whether Black folk became infected with HIV/AIDS through same-sex contact or through other means, Black church communities have too rarely been a source of comfort for the afflicted or their families. Again, AIDS stands for acquired immune deficiency syndrome, the key word being acquired. 30 years later, after I've acquired it, I'm absolutely convinced that the only reason why that I'm alive is because of God's grace and intervention. I believe that another one of the purposes of my extended life is to promote healing from the impact of oppressive and dehumanizing belief systems, and to empower the religiously disenfranchised to seek spiritual connection and fellowship. Like human beings themselves, belief systems are rarely all good or all bad, but they are always consequential. Notwithstanding partisan claims to the contrary, progressive and conservative beliefs each produce both negative and positive consequences. A particularly consequential biblical belief is that all have sinned and fall short of the glory of God. And just as consequential, whether orthodox or not, is the commonplace Christian belief that analogizes sin to disease. In its simplest form, the belief is that death and disease were brought into the world through the sins of Adam and Eve. The original sin is understood to have been passed through the bloodline to infect all of humanity with a sinful nature. And like disease, sin is seen as something that is both individual and communal in nature, which leads me back to HIV/AIDS. Speaking scientifically, HIV, like COVID-19, like monkeypox, is a virus that is completely uninterested in human morality. There are conditions under which it thrives and spreads, and conditions under which it does not. Individual and communal behaviors create the conditions that determine whether or not it will thrive in the human host environment. Unprotected sex and needle sharing, as originally seen in gay men and IV drug addicts, are conditions which aid the virus in spreading between hosts on the individual level. What is less acknowledged is how social inequality, stigma, and vindictive condemnation also create conditions that aid the virus in spreading, particularly in our most moralizing communities. In other words, the social determinants of health. It is no coincidence that by and large, governments and religious institutions did very little to confront the disease in the early days when it was associated with gays, drug addicts, and Haitians. It was a different story once it started spreading in heterosexual, hemophiliac, and white communities. Now, it was a pandemic. Similarly, monkeypox has been endemic to 11 nations, African nations, since the 1970s, but not until recently, when cases have been reported in the United States and Europe, has it become a subject of initial alarm in the rest. And yet, at the same time, somewhat muted by the for some comforting fact that it is mostly being seen in male-to-male sexual communities, which of course is the worry that if we associate this with gay people, we won't take it seriously until it's too late. Some of the unfortunate side effects of racism, homophobia, and other forms of community-targeted hatred are internalized hatred, higher rates of stress, and the consequent weakening of immune systems of the oppressed. There is a biological reason men who have sex with men and IV drug users are more susceptible to HIV than men who do not have sex with men and non-IV drug users. There is not, however, a biological reason that at only 13% of the US population, African Americans make up nearly 50% of new infections and nearly 50% of deaths, worse than any other ethnic community. Some of the reasons include a lack of testing, distrust of the medical establishment, particularly after our experience with the Tuskegee syphilis experiment, people being on the down low, and stigma. So given all the societal advantages of a heterosexual lifestyle and disadvantages, particularly in the Black community, of the gay lifestyle and anti-gay stigma, Black men with same-sex attractions are more likely to meet up in secret, or what we call on the down low, outside of their heterosexual relationships. In these cases, wearing condoms in supposedly monogamous heterosexual relationships would be a dead giveaway. And so too often they don't. And then there's also the power of internalized oppression and poor self-esteem. Essentially, if you're experiencing anti-Black and anti-queer stigma, or even anti-female stigma, you are less likely to defend your boundaries when same-sex pressures, around same-sex, when pressured by partners, and often fail to take even the most basic care of themselves. So that's a little bit about that particular community that I'm involved in. So I'd like to transition now to from the personal to a brief consideration of the spiritual and social justice aspects of the disease as I personally see it. Although HIV/AIDS virus is a biological entity, its success in becoming a global pandemic was greatly aided by the dysfunctions of our social structures, most notably in the forms of societal and internalized homophobia, structural racism, pious religious bigotry, and an indifferent, dehumanizing capitalism that puts markets over lives. For example, the exorbitant costs of drugs which put treatment out of reach for most of sub-Saharan Africa until the 21st century. At the risk of anthropomorphizing the disease, its success has been through its ability to exploit our defense systems on both micro and macro scales. In spiritual language, this is rendered as above, so below. It means that what is going on in our inner world is projected in the outer world and vice versa. So let's take sex, for example. Typically, receptive partners, female and gay male bottoms, are more susceptible to infection, but insertive partners, male and gay male tops, are more effective spreaders of the disease. That's the biological piece. But there's also social justice, spiritual piece. In many societies and cultures, women are expected to be innocent and submissive when it comes to sex, thus preventing them from accessing sexual health information and services. Also, many women and young girls are forced into prostitution to survive, or are bought and sold as sex slaves. For many men, masculinity is linked with taking risks and being tough, which it can increase vulnerability to HIV infection and discourage men from seeking treatment and testing. For generations, the sexuality and relationship of LGB folk have been criminalized and confined to bars and clandestine pickups. Even after the sexual revolution of the 60s and the 70s, when the gay rights movement began, social structures discouraged long-term relationships. It's much easier to hide a series of one-night stands than it is to hide a life partner. In the 80s, the mainstream perception of AIDS was that it was targeting the mostly undesirable, stigmatized groups, which of course is why there was not a coordinated, adequately funded response for the first 10 years. It wasn't until the disease started showing up in straight communities, celebrities like Rock Hudson and Magic Johnson, and children like Ryan White through blood transfusions that a threatened mainstream got serious about HIV/AIDS. But then, of course, it was too late. A disease that might have been contained if we thought the lives of those first infected were worth saving, burst through porous community boundaries to become a true pandemic. In much the same way the virus replicates inside CD4 cells and then spreads to other through the blood system. I'm feeling like I'm talking too much, so I'm gonna speed over a few things that I'd written here. I do want to say something about HIV in the Black church, however. A few years ago.
Sorry to interrupt. Our interpreters are asking you to slow down a little bit, please.
Oh, okay. Very well, I will. Sorry. A few years ago, the NWC tried to address the failure of Black churches dealing with HIV by launching the Black Church and HIV, a social justice imperative. In the manual, one of the ministers wrote, Martin Luther King said, there comes a time when silence is betrayal. For too long, the Black Church has been silent about HIV/AIDS. That is unforgivable, and it has to change. We have a moral, ethical, and spiritual obligation to seek out and support and embrace people who are at risk and who are living with this disease. Locally, a friend of mine, Akin Miller, tried mostly unsuccessful to engage local Black churches. One of those churches, in fact, wouldn't support the campaign simply because it referenced a female preacher. It is still true that some ministers, no doubt, still believe that it is a punishment for homosexuality. And yet, on the other hand, I want to raise up two octogenarian leaders in the Black community, Helen Rucker and Ruthie Watts, who have been active in HIV prevention in Seaside and on the peninsula for years. I feel like they have better internalized the Christian message of comforting the afflicted quite a bit better than the majority of Black preachers. I bring this example up because one of the things that AIDS has best exploited is our immature moral systems that neatly separate us into categories of saint and sinner, worthy and unworthy. There is nothing AIDS loves more than pious religions and governments that refuse to spend money or to pursue strategies based on their ideas about how humans ought to behave, instead of dealing forthrightly with how they actually behave. As above, so below. AIDS doesn't care whether you are an individual pretending that the next time you do drugs or get drunk, you won't fail to practice safe sex, or if you are a nation that refuses to acknowledge the AIDS epidemic because it's pretending its citizens don't practice the behaviors that might lead to AIDS. On the other hand, there were many positive responses to the epidemic in the queer community. One response was the rise of pressure groups like Queer Nation and ACT UP that fought to remove barriers and speed up the drug development process of the FDA. Another response was the development of alternative faith communities and spiritualities within the queer community, when many traditional faith communities had turned their backs on the community. Another is just the difference in how we think about these communities. We often would use the term gay community pre-AIDS. But because lesbians were less likely than virtually anyone to get HIV, they ended up coming back into the gay community in droves as caretakers. Whereas prior to this time, because of misogyny within the gay male community, lesbians most often caucused with women's communities. So that took us from the gay community, so-called, to the modern LGBTQ+ community. I'll end this part by saying that from a spiritual point of view, I see HIV/AIDS as a spiritual and moral test of individuals and communities, not in a dogmatic sense, but in the sense of our human capacity for compassion. And in order to pass that test and free ourselves from the horrors of this disease, we will have to apply the spiritual principles of truth, love, forgiveness, and healing, the opposite of which are the conditions in which AIDS thrives, namely lies, evasions and pretense, hate, blame, and shame. And then finally, what I'd like to do, and this is in the guise of, on the one hand, we don't want to call this a gay disease because it's not. But we also have to recognize that it is currently the community that is most at risk. So we have to think about how to talk to that community. And sometimes that conversation needs to be fairly private and within that community, because you have to talk in the language of that community. And particularly when we're talking about gay men who have sex with other men, we're talking about a very sex positive community. So here's something I found online that I'm going to share with you, and that will be the end of my presentation. Let's see. So this is Ducey's Guide to a Dory Alley Without Fear of Monkeypox. Says Dory is here, but so is monkeypox. Here are some ideas to reduce your risk and still enjoy your favorite kink and fetish festival in San Francisco. We're gearing up for an exciting return to our favorite street festival in San Francisco, up your alley, where you'll get your fill of hot, hairy daddies, hungry pigs, BDSM babes, and kinks of all kinds. Keep in mind that there are lots of ways to reduce your risk. They hope that you have a happy and healthy Dory Alley party. So first, don't skip the picky parties. We've heard from people who are worried about attending events out of fear of contracting monkeypox. We hope you partake while also taking steps to reduce your risk. It's been a long few years without community events because of COVID. We think it's time to get back out there safely, and if you feel comfortable doing so. Be aware, but not overly afraid. Monkeypox is transmitted from person to person during skin-to-skin contact with a person who has a rash, or contact with body fluids, like when kissing and when engaging in water sports. Even though it's technically possible to transmit monkeypox on surfaces, it's less likely. Play dress up. There's never been a better time to dress from top to bottom in latex or leather. Keeping your skin covered is a surefire way to prevent exposures to monkeypox. Keeping in mind, of course, what was said earlier about taking off that clothing very carefully. Take a friend to the dungeon. Going to sex parties with people you know and planning on who you'll hook up with can be one way to reduce your risk if you're able to have open and honest conversations about monkeypox symptoms and possible exposures.
Hey, Quasar, I apologize for interrupting, but we do need to move on so that Vanessa can present and we can do a Q&A. Can I ask if we can plug this link to this website into the chat so people can look through it on their own time?
Yes, I will just read the last three headlines and not comment.
Thank you.
Move to less crowded areas, enjoy what you're doing, and it's okay to be picky with your sex partners. That's it. Thank you.
Thank you so much, Stephen and Quasar. Next, we'll have a presentation from Dr. Vanessa Lopez Littleton, and then we'll have hopefully enough time for a couple of questions before closing. I want to make sure that we wrap up by 6:30. And with that, I'll pass it on to Vanessa.
Yeah, thank you so much, Ezra, and thank you, Stephen. And I'll do my best to get us out of here on time, even with a little time for Q&A. And so one of the things that I wanted to be clear about is why I chose this particular topic. So I've spent my career, well, the last 10 years of it, the last decade, talking about Black health disparities, in particular reproductive health outcomes. I focus on maternal and infant mortality, because I'm very concerned about the plight of Black women and Black babies in the United States. It seems like we've not been able to make the progress that I would have hoped we would have been able to make. And so anything that I can do to advance and create opportunities for people who look like me is where I want to be and what I want to do. And it's one of the reasons I got a PhD, so that I'd be able to do that. And so I did want to kind of blend in with what Stephen was talking about when he was talking about HIV/AIDS. And it's something that I studied probably about 20 years ago now. In thinking about HIV/AIDS right now, Black people have the highest rate of new HIV diagnosis in the United States. And that rate is 8 times the rate of what white people in the United States experience. That rate for African Americans is followed by Latinos, and they have a rate that is 4 times the rate of white people in the United States. And those are the disparities that we're up against. And one of the things that I want to make sure that I set some intention and point out today is that structural racism is alive and well and present within our healthcare system. And if we do not take the care to dismantle it, it will remain, and Black and brown people will continue to die at a disproportionate rate. So in my conversation with you today, I want to be, bring attention to these persistent disparities that we experience as Black people in the United States. I want to name and call out some of the ongoing challenges that we face. And then lastly, I want to kind of give you with something that I think are some of the necessary steps to take to overcoming and improving the health outcomes for Black folks in the United States. So this chart sums it up. It's about MPOX, right? And when we first started collecting data on it back in May, you'll notice that Black people represented, it was at about 29% of the total numbers of MPOX cases. But now we're up to 33% of the total cases. And the tricky part about this is if you have to look at this in context to the United States population. And so for African Americans or Black people, we only represent 13.6% of the population. And so what that means is that there is a disproportionate burden of MPOX on the Black population. But if you notice, that's also true for the Latinx population as well. So these are things that if we're not careful and we don't pay attention to, they will continue to disproportionately affect our communities, cause us harm, and lead to our demise. But that's what's happening in our society. And so I just want to send a quick shout out to Ezra and the team who put this conversation together, because it is very necessary that people understand how viruses, diseases, illnesses, and injuries disproportionately affect people of color. So for us, the challenge is sorry about that. The challenge is simple. There are stigma, and I think my colleague Stephen Goings did an awesome job of talking through stigma, so I won't spend too much time talking about it, but I will say this as it relates to the term monkeypox. And you'll notice I'm using MPOX. Our colleague earlier used that term, and I'm going to go with it because I think it's one of the things that we can begin to do to start to remove some of the stigma that's associated with it. We saw the same thing when it came to COVID. It just seemed like for some reason, once folks found out that these disparities were true, that more African American, more people of color, or more Indigenous people were dying from COVID, then that was when we saw a lot of the masks coming out, and a lot of people getting back out there and being more active. I'm not saying that there's data behind that, but darn, it sure felt like it, right? And so one of the things that we know is that anytime there is an opportunity to misuse, to weaponize these names in order to isolate or discriminate or stigmatize people, people will find a way to do it. And that's the level of racism that we can all strategize and act against, because we have power. We can call people out when they do these things. We can kind of ignore them, but that's not really what we want to do. We want to create a society that we all want to live in. And that society should be one where we value and honor other people. And so the one thing that I did want to kind of mention is about provider bias. As someone who works a lot with pregnant women, who are having babies, is that when we go to the doctor and we're telling them what our problems are, oftentimes our concerns are dismissed. They don't value our perspectives. They don't value our voices. And so as activists, as social justice warriors, that's where we need you to help us develop mechanisms and processes so that we can push back against these systems that systematically repress us or oppress us, So for me, if we are not able to address provider bias, the point of contact that we have with the healthcare system, we're not going to be able to end these oppressive systems. Structural racism, we have to be able to call out racism. And so if you don't know when I refer to racism, I'm talking about a system that structures opportunities and assigns value based on race. And race, as we know, is a social construct. And that happens within our healthcare system. And so if you listen to the experiences of Black patients, If you look at who is providing the care, the amount of wealth that they've been able to accumulate by providing the care, and the resulting poor health outcomes experienced by the Black population in the United States, you will quickly realize that there are systemic problems that are happening within our own society. And that, my dear, is racism. And we can't be afraid or too non-confrontational to call it out, or we will forever be in a perpetual cycle of it. And so my last slide really talks about the solution. And so for me, our solutions are at the individual level. You have to understand what racism is when it's internalized by individuals. So pushing back against a system really, can you guys see my slides or no? You can, okay, good. All right, so pushing back against a system really is about coming up with mechanisms and motives and opportunities that really address those stigmatized assumptions about an individual's own self-worth and abilities. And then the personally mediated racism. With personally mediated racism, that's where we get into this racist actions, discrimination, bias. So all of these things come into play when we're talking about health and health outcomes. And we can't be afraid to call people out for the things that they do that cause harm and create these disadvantages for populations such as African Americans. And so lastly, I'll kind of group these last two together, which is the healthcare system, the public health organizations, and even governments. We have a lot of work to do in understanding stigma, and these folks have big bucks in order to do research to provide care and services. So addressing bias and getting to the heart of discrimination and racism is truly one of the things that we need to do. So Stephen talked a little bit about the social determinants of health. You will see them there because all of these factors contribute to the differential health outcomes that we see. You'll notice I put racism on there. It's often not present when we talk about these social factors, but I think it's so important. It actually forms the heart of each and every one of these systems and the way that they manifest within our society. And so lastly, I think I did it, right? I think I have like 1 minute left. So thank you. And I apologize for having to truncate my presentation, but I too am a stickler for time. So thank you.
Thank you so much, Vanessa. So we do have 1 minute left. I want to do quick shout outs, and I'm happy to stay for Q&A if Vanessa and Stephen are as well. I don't know if our interpreters are able to though. We only have them until 6:30. So with that, I just want to thank our sponsors, Salinas Valley Pride Celebrations, Pajaro Valley Pride, Monterey Peninsula Pride, the Monterey County Black Caucus, and the Office of Monterey County Supervisor Wendy Askew, who's also provided interpretation services. Thank you. Thank you to Dr. Radner, Kristy, Mitchie, Stephen and Quasar, and Vanessa. You guys are so appreciated for coming out here today. With that, let's move on to a short Q&A for Vanessa and Quasar. Hopefully our interpreters can stay. If you have to go, we understand. And I apologize to anyone who is needing those services. But I do want to respect everyone's time. It is 6:30. That does conclude our seminar. We will be here for Q&A though.
I apologize for going too long.
I will take, no, Quasar, I'll take responsibility for that. We were supposed to break at 5:15. We breaked at 5:45. That's my bad. That's my bad. I'm the facilitator. It's not your fault at all. And your presentation was amazing. Thank you for that. Vanessa said in the comments, I love you, Stephen. You were great. It's also nice because we're all friends outside of this seminar space. We do have time for a question if anyone has one. If not, we can conclude and end.
All right, well, let's get out of here.
Let's get out of here. All right. Thank you everyone for coming to Monkeypox Informational Seminar, Science and Stigmas. This concludes our Epicenter presentation. Have a lovely night. Signing off.
Thank you, Ezra.